Hey guys, good afternoon. Alright, what we have for today, it's basically 75-year-old Caucasian male, so it's the age is older age. First, he came to the clinic recurrent syncope or lightheadedness. Syncope question is a kind of really, first it's high yield, second it's a kind of confused. So yeah, I prefer I will do really syncope question, sorry, maybe separate. But here basically we are talking about the cardiology. So lightheadedness during moderate exercise plus shortness of breath. So you have shortness of breath, which is dyspnea, and lightheadedness. Physical exam, boom, you have murmur. And this murmur is ejection systolic, so you can highlight the systolic one. Maybe the ejection one is also important. Where is it located? Located at the base of the heart. Now the murmur related to the neck. What's the problem here? And then he will give you options: aortic valve cusp, aortic root dilation, maximum generation of aortic cusp. So basically, if you will see the causes, or if you will see the options, so mostly he's talking about. Oops, sorry, let me change the color. Yeah, sorry, he's talking about aortic pathology, right? Which is usually aortic either root or cusp pathology. And you have another differential diagnosis here, which is ventricular septum, so septum pathology. So in this equation, so why this equation is basically, this equation aortic pathology versus hypertrophic cardiomyopathy. Okay, so this is basically the essence of the question. Now let's analyze the data. You have dyspnea here and you have lightheadedness, and this is basically one of the triad. So aortic, if I'm talking about aortic stenosis, which is usually here the case, the triad for aortic stenosis, guys, is basically you have three. Okay, so it's a kind of triad. So maybe you can say syncope number 1, all right, and dyspnea number 2, and then maybe chest pain. And this chest pain is usually on exertion, so angina. Shortness of breath sooner or later lead to congestive heart failure. So these are usually the triad, very common, really very high yield of aortic stenosis, and really not big deals. So it makes sense the angina patient will have chest pain and angina. Why? Because the blood supply that's going through the coronary artery is low, right? So here, yeah, so basically here is the aorta. Let's say here is the aorta. So these are the coronaries that's running through the aorta, small acute coronaries, right? So the blood, because it's already here, the stenosis, I mean the valve is stenosis, so decrease coronary, right, supply. That's why the patient have recurrent chest pain. Now, and the aorta sooner or later will go to the internal carotid artery, so also this will lead to decreased blood supply to the brain. That's why you have syncope. I mean, really, the symptoms is just easy, makes sense. Anything output through the aorta to the coronary artery will be decreased. That's why you will get recurrent anginal symptoms, which is sooner or later lead to congestive heart failure. Decreased blood supply to the internal carotid artery lead to syncope, right? So the syncope makes sense because decreased blood supply to the brain, internal carotid, decreased blood supply to the coronary supply. That's why you will get angina. So this is very common, really very common aortic stenosis pathology. Now, the causes of aortic stenosis, which is basically before, it's easy. Either, if you will see the patient around 70, so your answers will be it's calcium. So calcium deposit in the aortic valve. So this calcification problems. If you'll see it around 60s, maybe 50, the problem for those patients usually bicuspid aortic valve as a cause. Bicuspid aortic valve. Usually the aortic valve is tricuspid. That means you have 3 cusps normally. Bicuspid is just 2 cusps, and this is usually congenital. But the calcium will even deposit on this bicusp, but it's usually a kind of earlier presentations. Again, these are very high yield. Whenever you will see aortic stenosis as a pathology, if a patient is older age, goes with calcification. If patient in younger age, go with bicuspid aortic valve. So far, you get two important concepts here. You get the causes concept, so these are the causes, and you get history. right? Which is basically angina syncope. Let me delete this one because we already, I think, yeah, we already explained it, which is decrease the blood supply to the coronary or decrease the blood supply to the to the internal carotid artery. And then lastly, you get physical exam, right? On a physical exam, you hear, guys, it's always also a principle. You hear murmur whenever you have stenosis or maybe dilation. It's just turbulent blood flow. And the murmur, this is the aorta again, and this is the valve, right? So the valve will not open. And now I know this is always a kind of confused. Now, guys, aortic valve opens during what? What do you think? During systole or diastole? First, please, let's clear this up. It makes sense. When the valve open, the blood will go from the ventricles where? To the aorta. So in which case the blood will go from the ventricle to the aorta, basically? Is it during systole or during diastole? Or at least, I know systole and diastole as a word is also confused. Or at least you have to know that when the valve open, the blood will go to the aorta, right? So just imagine, let's draw this. This is the ventricle and this is the aortic valve. And now the valve open. So when the valve open, it's really easy. The blood will pump through the ventricles. This is, you have left ventricles, and here you have aorta. So what do you think? This indicate filling for you or output? You can say aorta means output. And whenever you have output means systole, guys. Yeah, I cannot imagine, really, you cannot imagine how a lot of students, even maybe me before, used to confuse systole, diastole. Is it filling? What is performance? What is action? What is cardiac output? Guys, always remember output when you have blood outside, which is usually when the aorta open. This is during systole. Now, failure to open the aortic valve. So aortic valve open during systole. This is filled. So you can say failure opening aortic valve, right, during systole, just ejection, and makes sense systolic murmur. Why it is systolic murmur? Because it's during systole. And why during systole? Because the only time that the aortic valve open in order for blood to come from the ventricles to the aorta. That's why during systole. Okay, I think this is really not so hard. So we clear this concept, physical exam. Now there is ejection click. I'm not sure about the click, is really important, but you have to know, guys, also this diagram about the physical exam. Yeah, by the way, media examination, which is the hard sound, are really important in step 1 and even in step 2. You will get at least around 4 medias question. Right, so you have to clear this up. Listen to the media through YouTube or Google it. It's really not so hard. Usually goes with systolic. Usually systolic is the, because it's easily to recognize. So this is S1 and this is S2 hard sound. Basically between S1 and S2, here you will hear a click. Yeah, it's ejection click. I'm not sure this is a click because the valve is stenosed. That's why you will hear a click. Again, I'm not sure this click is important. And after that, you will hear ejection systolic murmur. And it's a crescendo, decrescendo. So it's an increase and decrease. So this is basically the murmur area. Okay? So you will see the murmur usually looks like this. So this is crescendo, decrescendo murmur. Or you can say this is ejection systolic murmur. Again, this diagram is a kind of interesting. Some people don't know how to read it. It's really not so hard. You have S1, and after S1 you have a little bit of click, and after that you get the murmur, which is in increase and then decrease, and then you get S2. Right? And why is that? Because it's failure of opening of the aortic valve during systole. Okay? So I think that's what I have for, let me remember if I have more. I think that's almost what I have for aortic stenosis, which is, sorry, which is we have 3 things for aortic stenosis. So guys, you have to take care of. First, causes questions, and these are really high yield. So causes, number one. Second, maybe physical exam. Second, as we said, it's history, and you have the triad. And third, you have physical exam. Okay. There is a lot of other issue when we talk about physiology, especially the different ventricles and the gradient. But regarding pathology, I think it's fair. Now, as I always saying, it's wrong to study disease one by one. I mean, this study, which is aortic stenosis, is wrong. We have to keep it with hypertrophic cardiomyopathy, because both of them is systolic murmur. So whenever you will have systolic murmur, and you think this systolic murmur is a kind of aorta, I'm not talking about mitral stenosis. If it is right second, by the way, oh yeah, I didn't tell you it's right second intercostal space. Right second intercostal space. So yeah, sorry, I didn't tell you this is the right. So usually you will hear the murmur of aortic stenosis in the right second intercostal space, and this murmur radiates to the carotid. Right, radiated to the carotid. But basically the pulses here in the carotid is weak. Why? Because the valve is closed. So make sure, guys, you know this. It's also common sense. The pulse is all over. It's a kind of weak because because the valve is closed. So that's why the pulses is weak. So right. So basically this is in the right second intercostal space, radiated to the carotid. Now maybe you will hear a murmur. Oops, sorry. You will hear a murmur, but usually let's say. So basically here the first one is base. Sorry, and the second one maybe left sternal border. Now for those patients left sternal border, usually young athlete, you know all of that, right? Young athlete, syncope or decreased conscious level or sudden death. And here usually it's 60 or 70. We talked about 60 and 70. This is calcium. And the 60 was bicuspid. And I think you know what are these two diseases that I'm talking about. So basically the first one we just mentioned, this is aortic stenosis, right? And the second one is hypertrophic obstructive cardiomyopathy, which is how come? Is it high yield? Big time. They like it, they love it. Why? It's very easy to make a lot of the questions. Very easy people to confuse with aortic stenosis or with any systolic murmur. Sometimes people, when they hear systolic murmur, they don't know, oh my god, what's this? What's the murmur? It's mitral, aortic, pulmonary, hypertrophic, mitral prolapse, mitral stenosis. So when it's usually, now these are the differences first. So you get the first difference, which is the age. So you can say age is different. Plus also within the same difference, you get a cause. And here basically I said it's either calcium or bicuspid, while in HOCM, what is the cause of HOCM? Usually it's gene. So you can say, is gene a problem? And this gene is basically one of the protein that encode for sarcomere. So you can say sarcomere protein mutation. Then what next? This is because it's gene, so it's usually autosomal dominant. So maybe you will see here family history. Some family history, maybe uncle, maybe dad, right? So far you get two differential. Again, aortic stenosis, usually age of 60 or 70, you have two causes. For hypertrophic obstructive cardiomyopathy, you have another one. You have basically genetic problem usually, and these genetic autosomal dominant sarcomere protein defect or mutations. Now, history. Here you get here also it's very easy. Look at that, the history. So I already made the history, which is syncope, right? So this is the history of syncope, while the third one, which is, let's make it red, history, while history for the third one is the triad, which is, I will repeat it, syncope, angina, and what else? Dyspnea, or congestive heart failure, right? While the second one usually syncope, young athlete. So we done. What else? Pathology-wise. Now, the problem here is just aortic stenosis. So this is the aorta, and the aorta is just closed, right? And this is basically the left ventricle. So this is the left ventricle, and this is the aorta. While in HOCM, which is hypertrophic obstructive cardiomyopathy, look at the problem. The septum, usually it's big, and the septum is asymmetrical hypertrophy. So this is the septum. I hope I will draw it in a nice way. So look at the septum. So problem is interventricular septum. Septum. Now this septum during systole, this is basically, here you have the aortic valve, but here you have the mitral. So this is basically aortic valve area, you can say, almost. And here mitral. And this is very, very, very important concept. And this is anterior, you can say, anterior mitral leaflet. Now guys, during systole, because during systole and injection of blood, so during systole, the space between the septum and anterior mitral leaflet becomes closer. So you can say septum and mitral valve leaflet, which is the anterior, by the way. The anterior mitral valve leaflet becomes closer. And because the septum, which is this hypertrophied, now the mitral valve leaflet, which is anterior mitral valve leaflet, becomes closer to the septum. That's why the patient will have what? Ejection systolic murmur. So this is the cause why there is ejection systolic murmur on the left sternal border. Again, during systole, when the blood pressure, during systole, when blood moving out, or when there is ejection of blood out, the septum, which is because it's hypertrophied, will become closer to the anterior mitral valve leaflet. So when it becomes closer to the anterior valve leaflet, now the blood flow will be a kind of turbulent. Why? Because just a closer area, so you will decrease the distance. And once you will get turbulent blood flow, in this case you will hear a murmur, and this is basically down. That's why you will hear it in the left sternal border. So that's why, this is the reason why there is murmur. Let's make another color. That's why you will get murmur here, which is systolic murmur, harsh left sternal border. So I said it's systolic murmur from the beginning. I said left sternal border. And now, why there is murmur, this was the explanations. The septum becomes close to the leaflet. For the second one, why there is murmur? Because aortic stenosis, or narrow orifice. That's why we get murmur. And we mentioned the murmur of aortic stenosis is usually ejection systolic or crescendo decrescendo. So far you get these differences, which is very high yield, very important. And I think really it's interesting. Okay, so again, the murmur. Why there is murmur? Because the septum becomes just closer to the mitral valve during systole. That's why you will hear murmur. All right, so you get the following. How you will read it? Again, guys, you will not read the stories and please lines. Be away from this habit. Always telling my student, hey, you cannot make 7 books with a lot of updates sometimes, different concepts sometimes, different Q banks. You cannot make them by just stress on all of these details. You will stay focused on details, but in different ways. So for example, now, younger patient systolic murmur plus maybe, younger patient systolic murmur athlete, you get syncope, number 1. You get gene problem, number 2. You get murmur, and this murmur because of the anterior leaflet and septum pathology. So that's it, guys. And this murmur is left sternal border. So whenever I will tell you something about Hucum, you have just your response to be quickly syncope, gene, systolic, anterior valve, septum, left sternal borders. 5 words. Whenever you hear something about aortic stenosis, your response will be the following. Triad, which is syncope, angina, chest pain, syncope, angina, dyspnea, this is number 1. Second, 2 causes, younger and older, which is basically bicuspid and calcifications. And the third thing is ejection systolic murmur. So that's it. That's it. It makes sense. Everything, or the blood supply to the whole body, will be weak. That's why the pulses will be the delay carotid or carotid pulse will be also weak. And there is something called, I forget it, parvastardus, which is basically delay or weaker carotid pulse or weaker blood supply in compared to the other pulses, and compared to the heart sound. So the weaker, you will see weaker pulses. All of that just aortic stenosis. Again, guys, just by words. Just in the next video, because I think I'm running out of time. Next video, I will go with maneuvers. So still this video, there is a continuation, because there are maneuvers that increase the murmur in case of Hockham and decrease the murmur in case of Hockham. And I think these are really very, very high yield and kind of confused. All right, guys. So thank you for watching this video for today, and we'll see you soon. Thank you.